Hello guys, and welcome back to the channel. And in today's video we are doing a little bit of a sit down educational video, so grab your cup of tea, lock in, because we are going to cover all things PCOS, identifying and understanding the root causes of your PCOS. Interestingly, as I have gone to record this today, PCOS has actually been renamed as of yesterday to PMOS, which stands for Polyendocrine Metabolic Ovarian Syndrome. We are absolutely here for this because PCOS implies polycystic ovarian syndrome, implies that women are just presenting with cysts on their ovaries, and that is so far from what the condition is. The truth is, a lot of women with PCOS don't actually even have true cysts. It is not just a gynecological issue, it is a hormonal and metabolic condition. This new name definitely now reflects that a lot better. Now through this video, I'm still going to refer to it as PCOS because that's what we all know, that's what we're all used to, but just know that I am referring to that overall broader term of PMOS. In my opinion, PCOS has become the IBS of the hormone world. If you're struggling with your periods, if you're struggling with any sort of hormonal issues, you have probably gone to your doctor and gotten a PCOS diagnosis. And this is a huge problem with these diagnoses because PCOS isn't just one thing, and treating it as one is a reason so many women still suffer years after having a diagnosis. So in this video, I'm going to break down what PCOS actually is, how you get a diagnosis, and the 4 different types, because understanding this is everything when it comes to supporting your body. Let's start with how PCOS gets diagnosed, because this is where the real confusion begins. PCOS is diagnosed off a criteria known as the Rotterdam criteria, and in order to receive that diagnosis, you need to tick 2 of 3 of the boxes. The first one being the presence of high androgens, and this is either present on a blood test or you have symptoms of high androgens, such as facial hair, hair thinning, acne, even mood changes. And number 2 would be the presence of polycystic ovarian morphology on a scan. What we need to recognize here is all women have follicles on their ovaries. We develop them through our menstrual cycle until one matures and triggers that ovulation. What we're looking for in PCOS is not true cysts, it's the presence of stalled or undeveloped follicles. And the third criteria is absent or irregular cycles. And when we speak about absent cycles, we're generally speaking about having no cycle for over 6 months or very irregular bleeds. If you have 2 of 3 of these criteria, you will walk away with a PCOS diagnosis. And that is where the problem starts. A lot of women who are going into their doctor with a diagnosis of PCOS, the first thing they're being told is that they're insulin resistant, they need to cut carbs, they need to lose weight, they need to cut out all forms of cardio. And honestly, for some types of PCOS, this can actually make it worse. Other than this advice, the only treatment options available for PCOS is the contraceptive pill and things like metformin. The thing to recognize with the contraceptive pill is that it does not regulate our cycles. How the pill works is by shutting down ovulation. So our body isn't going through that natural process. That bleed we see each month is a manufactured bleed from when we take the pill out, and more so what we would call a withdrawal bleed. Metformin, of course, can have its place, but only when insulin resistance is present. When we have PCOS without the presence of insulin resistance, using metformin is giving you probably all of the GI side effects without the benefits. The reality is these options don't get to the root cause of the PCOS, and this is what this video is about. So let's talk about the 4 different types of PCOS. We have insulin-resistant PCOS, adrenal PCOS, post-pill PCOS, and inflammatory PCOS. Each of these have a different driver, different symptoms, and different approach on how we manage them. So let's go through them. Firstly, we have insulin-resistant PCOS, and this is the most common type of PCOS we know. Insulin is a hormone made by our pancreas, and its job is basically to escort glucose into the cell. When we have insulin resistance, what happens is our cells stop responding to that insulin properly. Our body compensates by producing more and more insulin, and our blood glucose rises. Over time, this causes a cascade of downstream effects, and one of them being androgen excess. And what's happening when we have this chronically high insulin level is it's disrupting signaling at a brain level, specifically something known as GnRH, gonadotropin releasing hormone, which then throws off LH and FSH, those pituitary hormones responsible for follicle development and triggering ovulation. You often also see that classical elevated LH to FSH ratio in this type, generally 2:1 or 3:1. Symptoms to look out for in insulin-resistant PCOS are things like energy crashes between meals, cravings for things like salt and sugar, lack of fullness cues, feeling sweaty or even shaky after meals, weight gain, especially around our midsection, that darkening of those folds like our armpits and groin, also the typical facial hair. When we're testing for this type of PCOS, we want to look at things like glucose, HbA1c, and a fasted insulin level. Of course, along with those sex hormones and a comprehensive panel to see a full overview. The second type is post-pill PCOS, and this is the type that I most commonly see dismissed in conventional medicine. Nobody was put on the pill at 16 and warned that coming off the pill years later may trigger something that looks exactly like PCOS. So what's happening here? Hormonal contraceptives such as the pill and also the hormonal IUD to a lesser extent work by suppressing ovulation through synthetic hormones. While you're on these, essentially your own natural hormone production is switched off. When you come off them, we can see this like rebound effect, specifically in androgens, which can produce those classical PCOS type symptoms. And what we'll typically see here is all of those high androgen-like symptoms: jawline and cystic acne, hair thinning, facial hair growth, and irregular or absent cycles even after coming off of the pill. After coming off the pill, it is completely normal for it to take 1 to 3 months for that cycle to return. I wouldn't normally suggest running any sort of blood work until that time has passed and making sure you're supporting your body in the meantime. If that time has passed and you're not seeing that cycle return normally, that is when I would start to look into more blood testing and even more functional tests, so like Dutch tests. The third type we want to look at is adrenal-based PCOS. And honestly, this is the most mismanaged type because the general advice for PCOS can actually make this type worse. Adrenal PCOS is driven by dysfunction in what is known as the HPA axis, hypothalamus pituitary adrenal axis. When you're chronically stressed, which can come from so many different things, external factors like work, relationships, even things like mold exposure, gut pathogens, nutrient deficiencies, so many things can put our body in a state of stress. When this happens for prolonged periods of time, what we can see is this dysregulation in that HPA axis. And that dysregulation can then cause a PCOS-like hormonal picture. The key marker we want to look at here is DHEAS, which is the sulfated form that we test in blood. When we see this elevated DHEAS, along with a relatively normal LH and normal ovarian testosterone, that is where we start to think that there is this adrenal involvement. I'm sure a lot of you listening to this will have heard of the phrase lean PCOS, and this is generally what that's referring to. At the time, these women struggle to get a PCOS diagnosis because they're not presenting with the typical being overweight. And actually, in fact, a lot of these women can be underweight. Typical symptoms we'll see present with adrenal-based PCOS is that feeling of being wired but tired, energy crashes through the day, difficulty falling asleep or even staying asleep. That feeling when you have caffeine and it feels like it just doesn't work for you, or you're feeling more exhausted after having it. Even things like anxiety, nervousness, shakiness, these can all be things that show up alongside. There's actually something really important to recognize when we talk about adrenal PCOS, because a lot of the symptoms that present with adrenal PCOS can be very much related to those that present with hypothalamic amenorrhea. This is the loss of your cycle due to high stress in your body, which can be from undereating, overtraining, all of those kind of things. As you can imagine, if somebody with hypothalamic amenorrhea went into their doctor and received a PCOS diagnosis and followed those general guidelines, like to cut out carbs and to lose weight, you can put 2 and 2 together and recognize that is going to make the situation so much worse. This is exactly why proper testing matters, not just kind of listening to these symptoms and kind of matching them up with how you feel. And when we look at testing for that adrenal-based PCOS, of course, we want to look at that comprehensive hormone panel, including that DHEAS, as well as things like cortisol, which can be incredibly useful. The thing to recognize with blood-based cortisol tests is they're not always accurate. A better way to test cortisol would be to use a saliva or urinary test, but these are more functional-based testing, not something you will get from your doctor. The fourth and last one we're going to speak about is inflammatory PCOS. This one is driven by this chronic systemic inflammation, which disrupts that hormone signaling. Inflammation is not inherently a bad thing. In fact, it's actually our immune system doing exactly what it should do, sending out white blood cells in response to injury, infection, or even threat. The problem occurs when there is this chronic low-grade inflammation constantly going on within our body. When inflammation is constant, it creates like this noise at that brain level, and our HPA axis reads this as a threat. One thing our body is great at doing is that when it perceives these threats, it basically can downregulate anything it doesn't deem as essential, and ovulation is going to be one of them. What we generally see in inflammatory PCOS is more of a whole body picture, We can see those irregular or absent cycles. We can sometimes see high androgens. And what we can often see when I speak about all of these types of PCOS is kind of different drivers from each. And again, this is why it's so important to take your body for you and not this general guideline of you have PCOS, that is it. Symptoms we can often associate with this type are things like fatigue, brain fog, aches, pains, even gut issues like constipation, bloating, gas, potential overgrowth within that gut environment, things like skin issues, eczema, psoriasis, even acne. Testing for this one can be that little bit harder as it requires us to kind of look at this whole body picture. One of the inflammatory markers we generally look at on bloods is CRP or HSCRP, but it's also very useful to obviously look at comprehensive hormones, things like glucose, HbA1c, fasted insulin, lipids, and honestly, really just an overall comprehensive plan. So those are your 4 types of PCOS. We've got insulin resistant, post-pill, adrenal, and inflammatory. And understanding what is driving it for you is so incredibly important when it comes to supporting your body. As I mentioned with that adrenal-based PCOS, and when we look at that insulin-resistant-based PCOS, which most of the advice is given out around, applying that to things like that adrenal-based one is not going to work. And if anything, it makes it worse. And honestly, the fact that this condition got renamed this week after 11 years of pushing for change says everything. I truly believe that the medical space is starting to catch up with what functional health has known for years. What is now known as PMOS is not a problem with your ovaries. It is a multi-system metabolic and hormonal condition, and it should be treated like one. If you are suspecting, or maybe you already have a PCOS diagnosis and want support understanding your type and how to best work with your body, this is the exact work I do as a coach. There is a link within the bio to apply to work one-to-one with me. Hit the link there. Let's have a chat about how I can help. And as always, make sure you're subscribed for plenty more educational and life videos just like this. And if there's any specific topics you want me to cover, just drop them in the comments below.